The treatment of ILD is broad, depending on what kind of ILD. If you have more of an inflammatory ILD, say, for example, like ILD due to connective tissue diseases, scleroderma being an example, then a lot of times we'll use immunosuppressive therapy. The go-to medication these days is mycophenolate mofetil. If you have ILD that is more fibrotic, and IPF being the prototypical illness, then we have two antifibrotic therapies approved. Both were approved at the same time in 2014. The first one is pirfenidone, the second one is nintedanib. Pirfenidone is indicated for the treatment of IPF. Nintedanib has a little bit of a broader indication. It's indicated and has FDA approval not only for IPF, but for scleroderma-related interstitial lung disease, as well as what we term progressive fibrotic interstitial lung disease, which encompasses a number of different conditions that have in common some manifestation of progression of their disease. If you look at other therapies, actually just very recently approved just this year for scleroderma in particular, is an IL-6 receptor blocker, that's tocilizumab, which was approved just very recently for the treatment of scleroderma. So those are the major therapies that we use. The other therapies that we sometimes will resort to, like in CTD ILD or connective tissue disease-related ILD, like rituximab. But the ones that are approved and have a specific FDA label are nintedanib, pirfenidone, and now tocilizumab. Even though we use mycophenolate a lot in various forms of interstitial lung disease, it doesn't have a specific label, FDA approval to treat these conditions, but that's pretty much a standard of care for many of the so-called inflammatory ILDs. Like any condition, the ILDs can be difficult to treat. Sometimes, despite our best medications, these patients have an intractable progressive course. In fact, if you look at the most common indication for lung transplantation, it is interstitial lung disease. So while we have options available, we've got a long way to go with therapies in terms of trying to arrest the disease in everyone and ideally to reverse the disease. There are also some patients who are intolerant of the medications. If one looks at the antifibrotics like nintedanib and pirfenidone, anywhere from 10 to 20% of the patients won't be able to tolerate these and have to come off therapy. Medication like mycophenolate also has side effects. And so there's a lot of room for further drug development for these various conditions. Now, I will mention one other medication that just got approved, and that's inhaled treprostinil. Inhaled treprostinil was just approved for pulmonary hypertension related to interstitial lung disease. Inhaled treprostinil is approved for group 1 pulmonary arterial hypertension and just got approved and is the first drug approved for group 3 pulmonary hypertension. Group 3 pulmonary hypertension is pulmonary hypertension due to lung disease, and now it has a specific indication of pH related to interstitial lung disease, targeting pulmonary hypertension, which can complicate the course of most of the fibrotic ILDs. There is a body of literature suggesting that the disease prevalence of ILDs is increasing. Whether or not that is environmental, whether or not that's increased discovery, whether or not that's an aging population is uncertain. We tend to get many more CAT scans these days and find incidental interstitial lung disease. There was actually one paper looking at this from various large registries and databases. And if you CAT scan folks out in the community, anywhere from 7 to 9% of them will have early interstitial lung abnormalities. How many of those go on to develop frank, clinically manifest interstitial lung disease is uncertain. So I think in many ways, maybe we are seeing a little bit of the tip of the iceberg, and there's a lot of ILD that's out there. I think as you have an aging population, something gets us all at the end of the day. And as we conquer all these other diseases, and as folks live longer, we're probably going to see even more interstitial lung disease. Then there are also emerging causes of interstitial lung disease. And what we're seeing today, for example, is post-COVID. There are many patients who've had COVID infection, COVID pneumonitis, who are left with some residual interstitial lung disease. We're still trying to learn about that, being that the pandemic is not that old. How much of this will be a problem in the long haulers is uncertain, but I think that this is an emerging problem. and perhaps another cause of interstitial lung disease that we'll have a greater appreciation of in the future.